Good morning, everyone. Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for this morning's session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be starting us off with a few quick announcements, and we'll be facilitating today's session. If you've not already done so, please put your name, email, address, and affiliation in the chat box. We ask that you please stay muted unless you're speaking. You can use *6 on your phone to mute and unmute, or you can click on the microphone icon on the bottom left-hand corner of your Zoom screen. You may also use the chat for communicating during the session. We realize that question and answer time is important to you, and we're trying to categorize and address as many questions as possible. But if there are any open items after the session, we always follow up via email. If you have suggestions for future COVID-19 echo sessions, please share via the chat tool or email us at echo@psu.edu. Please remember that when we discuss cases, no personally identifiable information is allowed. We are recording these sessions, and we share all materials and recordings after the session. In the spirit of all teach, all learn, we'll be on a first name basis during the session. For those of you who are new to Project Echo, our Echo sessions always begin with a brief lecture and are either followed by a case discussion or Q&A. Cases can include a question or a challenge you want to address. We encourage you to submit cases for future sessions. The link to submit cases is always included in our follow-up emails. Today's session will include a brief lecture on COVID-19 clinics by Drs. Emily Link and Laurie Nelson. We'll pause briefly after the lecture for any questions, and then they have some cases to share as well. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State Online, and they will help to field questions. But please remember, this is all teach, all learn, so everyone can share both questions and answers. And with that, I'm going to turn things over to Emily and Laura for our brief lecture.
Thank you, Jackie, and thank you everybody who's joining us this morning. So as Jackie mentioned, Laurie and I are primary care internists with Penn State Hershey, and we work in a practice here physically distinct, but on the campus of our medical center. We're going to be talking to you about our acute pandemic clinic. So probably like many of you, 4 or 5 weeks ago, we were seeing our patients in clinic, our usual routines, and now we find ourselves, dressed in scrubs, sitting in a closet, talking to you about highly infectious pathogens. So clearly the practice landscape has changed for all of us, and our hope for today is to share some of the tips that we've learned, and hopefully perhaps even learn some of the practices that you found helpful in evaluating your patients during this time. Laurie, you want to say hi too?
Hi, good morning. I'm Dr. Laurie Nelson. It's nice to meet you all, and hope to have a good interactive session today.
Yeah, so like I mentioned, our hope for today is that we can sort of identify the patients that we've learned may benefit from or require a non-emergent face-to-face evaluation, and share some of the practices for evaluating these patients either with fever or respiratory concerns during the pandemic in the safest manner possible. We've brought a couple clinical cases, but my hope is as you have questions, and please feel free, we hope this is more interactive, to kind of bring up any questions or comments you have, and Jackie has assured me she'll be monitoring the chat box carefully. So, yeah. So caring for our patients with respiratory concerns. So like I mentioned in the past, this would be a no-brainer. It's allergy season. We just got through kind of the bulk of flu season. You bring these patients into clinic, you might mask them, you evaluate them, and you don't give it a second thought. And this algorithm has sort of totally been upended by the COVID-19 pandemic. And so, again, like many of you, Laurie and I are doing a lot of home management and telehealth management for our patients, both for their acute concerns and for their chronic conditions. And so then you find yourself in the position of, things are going okay with telehealth. Maybe a patient you're concerned about might be taking a turn for the worse, and then you're left with do I send that patient to the emergency department, or how do I best evaluate them? Is there another option? So Laurie and I would argue that there is. And for us here, this building that you see here is the practice that we used to practice in. You'll see the two kind of canvas tents outside. And Laurie will talk a little bit about sort of how this transpired. You wanna?
Sure. So this was our West Campus clinic. It was just a small clinic where we were all just attending physicians in there. We did some teaching with medical students, but relatively small practice site with 10 exam rooms total. And we had probably 13 docs that would rotate through that had a lot of other responsibilities. Dr. Mosier is our Vice Dean for Education, for example, was one of our doctors. So we were the first clinic that was essentially closed when we were ramping down. And they consolidated us to the East Clinic. And the medical group, being forward thinking, figured that there must be some need to be able to evaluate patients in the outpatient setting that would be COVID positive patients. So they quickly changed our clinic and put a negative pressure in for all of the exam rooms and added chest x-ray and whatnot immediately, but not really knowing exactly how, what patients would be rotating through there and whatnot. So we had to come up with a criteria. Emily and I kind of volunteered for this, both being kind of ex-military. We kind of wanted to be on the front line. And so we just kind of been created the criteria for this clinic, kind of ourselves, and it's been evolving. And so it was kind of an interesting transition to come back to our clinic and have it be something totally different.
Yeah, and so the guiding policy that we've sort of adopted from our division leadership has been to provide the best care we can for our patients during the COVID-19 pandemic while maintaining our own health and safety and the health and safety of our patients and staff. And so I think this clinic, and I think in various settings, a lot of our primary care partners will be able to stand something similar up that does meet both of these goals. So here's the sort of entrance to our exam rooms that's been blocked off as a negative pressure suite. So here's what we offer. We do medical assessments, clinical evaluations. We have always an internist and a family practice physician here, so we can provide care to the broad spectrum of age ranges. We have chest x-ray units, and the capacity to do phlebotomy, provide our patients with home supplies to include pulse oximeters and thermometers that they can take home to assist their own primary care doctors with continued telemanagement. And we have the capacity to expand to include OB assessment. The obstetrics and radiology departments have put a OB ultrasound in one of the exam rooms, and then virtual consultation with social work and possibly palliative care. So what patients might be appropriate for outpatient clinic? And so the initial criteria we developed was people who are having difficulty breathing or shortness of breath in the context of known COVID disease, persistent pain or pressure in their chest, or perhaps a pulse ox slightly lower than their baseline, slight tachycardia, but without obvious, 2 to 3 word conversational dyspnea, cyanosis, clear respiratory distress that would sort of warrant an emergent referral. So considerations for patient safety. So for all of our COVID-19 patients, we evaluate them in a negative pressure suite. We have a dedicated nursing staff that is assigned exclusively to our clinic that has been trained in appropriate donning and doffing of PPE. We have the dedicated portable x-ray machines, the ultrasound that I mentioned, and IV infusion capabilities. Now for our patients under investigation, and so initially many of these patients were patients who were commercially tested for COVID, but during the early April when the tests were still taking 1 week plus to come back, were not laboratory confirmed, or perhaps patients with fevers who their primary care doctors didn't feel comfortable bringing them into their own clinics in their own vulnerable patient population. We evaluate them in tents outside of our facility. And our radiology department has stood up a drive-through chest x-ray, and I'll show you pictures of that because it's really quite neat. And we can perform all the same evaluation outside in our tents as we can inside. So that would include labs, EKG, nasopharyngeal swabs, and we have even done IV infusions out in our tents, and that's worked quite well. And so here is an example. Again, this is a time where I think we all need to be thinking outside the box in terms of both patient safety and preservation of the PPE. And so here is our East Campus. So this is on our campus as well. This is one of our internal medicine clinics that our radiologists actually, if you look, the picture on the right is the parking lot. This is a drive-through chest x-ray. So patients can drive up, park right there, and then the patient will go stand under that blue tent. And what you see under that blue tent is a door has been removed from the clinic and replaced with a plexiglass barrier. So that is a completely sealed off space. And there's one radiology technician outside in full PPE who positions the patient outside of that plexiglass. And the other radiology technician who stands inside with the actual portable chest x-ray machine and shoots the image, they don't have to wear PPE. They're completely sealed off. And the chest x-ray machine itself is also completely sealed off. So really the only thing that needs to be disinfected is the material outside. And so I thought that was, really, it's been very well received, and it's been used with a lot of success. Other special considerations that we've sort of encountered, direct hospital admission. So some of these patients, so usually the patients we see, we're seeing them because something about them, something about their evaluation over telemanagement makes their doctor, their provider concerned. And so some of these patients will require hospital admission. So of the first 24 patients that we saw, we directly admitted 2 of them to COVID positive inpatient units. And so I think it's important to have a good relationship and good open communication with your EMS in your area. So our EMS has been here. For direct hospital admissions, the EMS needs to be alerted that they will be transporting a COVID positive patient. They don their PPE. And then they actually, at our institution, they will take the patient directly to a separate entrance apart from the emergency department and transport them directly to their room on a COVID unit. And the other kind of special consideration is BLS. So on last Friday, the AHA released interim guidance on BLS and ACLS for healthcare providers caring for COVID positive patients. And I included their algorithm, not because I want you all, I know it's very small, but because this is free online on the AHA website, and I've posted it there. And we've actually printed these off in color, attached it to our sort of code box. And I find it's really very similar to the BLS that we're all familiar with the couple exceptions. Number one, you want to verify the scene safety, so donning PPE and then limiting personnel. So that's the big kind of take-home point there is chest compressions and any sort of ventilation, even during BLS, not even ACLS, but BLS is aerosol generating. And so really important to have protocol in place in your practice to minimize the number of people exposed to that. And so we've actually practiced that here with our nursing and radiology staff. We've had some simulated codes to work on how do you clear that scene, because that's something that's a little different from, I think, what most of us are used to with normal BLS algorithms. The other thing I'll point out is any sort of ventilation that you're doing with a bag mask device, it needs to have a tight seal and a HEPA filter. And so that's, again, something new during this pandemic period. And then we have a couple cases, but I wanted to just pause before we went over them and just see if you guys had any questions.
So Emily, since you're not able to see the chat, there was one question about bad weather, what happens
Yeah.
then, but Laurie did go ahead and address that. So I don't know if there's anything else that you want to add before we move on.
No.
I just wanted to say one thing about the bad weather. Last week we had rather severe wind, and we had to drop those tents. Just as we have a drive-through tent also here at Penn State to do the testing, and they had to shut down as well. And so we ended up doing a few things extra because of that. But we're very careful about bringing the PUIs. We treat them just as if they are COVID positive, and we bring them into the space, but we're very careful to keep them separate, and certainly separate from the COVID positive patients. In between, I think we do even more cleaning of our PPE from one PUI to the next, maintaining their safety as well as ours.
Yeah, and I would say, so the rain has not been an issue as much as the wind. The wind is really the big issue. And I've actually, I've tried, when our tent shut down, I've tried to do a nasopharyngeal swab in a patient in a car in the wind. And it's just, it's not something, if the wind is high, that's something that unfortunately you can't do. The face shields kind of go flying across, the gowns go flying, and it's just not a safe, that is not a safe thing to be trying to do. But yeah, good question. Any other questions?
Doesn't look like.
Great. So let me just go, so case one. So Laurie and I tried to kind of pull a couple representative cases that we've seen so far early in these first few weeks of the clinic. So case one, Miss S is a healthy 40-year-old woman, really no underlying medical conditions. And we were called on her the first week we were open by her family physician. So on the 14th of March, she developed diffuse myalgias, back pain, overwhelming fatigue, and diarrhea. And she was quite specific. She didn't really have a bothersome cough or really any shortness of breath at all. It was really just this sort of overall kind of feeling crummy. So this persisted, and she says what prompted her to go to the emergency department was actually diarrhea and fevers. When she was in the ER, on review of systems, she mentioned this mild cough, and they swabbed her for COVID-19. So curiously, her son had the exact same symptoms. She had a teenage son, and he was evaluated the same day, also swabbed. She returned COVID positive. The son's COVID nasopharyngeal swab resulted as COVID negative. So kind of a curious, we sort of attribute that to the sensitivity of the test. We consider him a false negative. But she was instructed to manage at home. She had mild disease like most patients will. So she went home, significantly improved over the next couple days. She said she didn't get better. She still had significant fatigue, but the diarrhea was gone. Fever seemed to abate. And then on 7 days later, she called back because she was having recurrent fevers, and she had this new chest pain and a worsening cough. And this was one day after she had received her results. So her family medicine doctor was really following her quite closely, and she called me on April 1st, and she said, this patient called in again today. She's concerned about pneumonia. She's having a worsening cough, new chest pain, but she's speaking in complete sentences. She sounds okay. I really don't want to send her back to the emergency department. She didn't think she needed emergency evaluation. She said, but I would love to just have somebody take a look at her, get a pulse ox and some vitals at least, and listen to her lungs. And so I thought that was kind of a perfect referral to our clinic. So Miss S came in, and here you can see her exam. So she hemodynamically stable, afebrile, extremely anxious appearing, but she was speaking in complete sentences, no conversational dyspnea. She had clear lungs, and her heart exam was, she had a normal cardiovascular exam. She just had a lot of tenderness on palpation of the chest wall. So throughout her entire anterior chest wall. So this is kind of a pattern we've been seeing. A lot of myalgias, tenderness over the back and chest. We did do a chest x-ray, and she did not have any evidence of pneumonia on chest x-rays. So I don't know, any thoughts? I don't know if anybody wanted to share any thoughts on this patient or any questions about this patient. Let me see if I can bring the chat box up.
And if there are questions, feel free to unmute your microphone as well.
Yeah, thanks. Okay, so so she was evaluated in clinic, discharged to home. So some reassurance, and you know, we get the question. This question comes up a lot. How long is this going to last? So if you notice, she had symptoms for over 2 weeks, almost 3 weeks already, and we've been seeing quite a variable presentation, which sort of matches the early data coming out of China. So the WHO, China, they had a joint report, and they said the sort of for people with mild disease, symptoms last on average 2 weeks. For those with severe disease, on the order of 3 to 6 weeks. But again, that's highly variable. And so she was evaluated in clinic. She did continue home rest, supportive care, you know, Tylenol. Her symptoms were improving. Her family doctor called her the next day. Symptoms were improving, and then continued to follow up by telehealth, and her symptoms were completely resolved by 4/10. But you can see there almost a full month that she had symptoms, and so that's not totally unusual for the patients that we've seen. And so here, trying to get data, because again, we're getting a lot of questions like, how long is this going to last? And what do patients in the ambulatory setting look like? So I think we know that the majority of people will have mild disease and will not need hospitalization, but what do they look like? Because a lot of the data coming out, a lot of the published literature is on hospitalized patients and ICU patients. And so this article I put up here, I thought this was very interesting. So these, they looked at the clinical characteristics of non-critically ill patients. And if you notice, it's in this Hong Kong hospital. So it says hospital, it's a little, that term's a little misleading. So what these were, there were 16 of them set up in the most heavily afflicted province in China. And they were essentially sports arenas that they modified for people with only mild disease. So these would be patients who we would probably manage at home here. So they had to meet certain clinical criteria. They could not be older than 65. They had to be ambulatory, meaning they could walk by themselves. They didn't need anybody to care for them. They were COVID positive patients who did not have severe disease as by a respiratory rate that was less than 30, pulse ox greater than 93%, and no significant, they did not have significant chest CT, pneumonia on chest CT. So this approximates, I think, the patients that we see in an ambulatory practice pretty well. And so they looked at their presenting symptoms. And as you can see, the sort of the most common fever, cough, of course, and then dyspnea and myalgias. And so I would say, I've been struck here, and maybe Laurie can chime in, but the amount of patients who are they're having these myalgias, it is significant. And so that's kind of reflected as well.
Yeah, Emily, and I think it's been kind of distinct with this chest pain. You know, a lot of people are chest discomfort or chest pain. Not the way they describe it is not cardiac-like. That's what they worry about. And we have been doing a fair amount of EKGs in the clinic here with little or no changes on the EKGs. It's not showing like necessarily a pericarditis. We don't see the diffuse ST segment changes. And so it's a very different chest pain than what otherwise people would describe with other illnesses. And it also doesn't seem like the rib-like chest pain from coughing necessarily, and it's not always a costochondritis-like symptom. It's just it's almost like a distinct entity, don't you think, Emily, that this chest pain is very, very different?
Yeah, and the best I can chalk it up to is myalgias, because many of them have tenderness on palpation of the muscles of their paraspinal muscles as well, but it's very reproducible. And so yeah, it's been kind of some of our early experiences sort of has sort of borne that out. And so for this patient, let me see if I can advance the slide here. So I guess the take-home point from this patient is that most cases are mild, but they're still very, very uncomfortable. And there's a lot of anxiety, as I'm sure all of you who are calling these patients daily, who are following these patients know. And it's very understandable. I mean, you turn on the TV and you see sort of the doom and gloom coming out of New York and other places where there's severe disease. And so we're not getting a lot of exposure to people who do just fine at home. So there's a lot of reassuring that we can do. And I think that we have been doing, oh, your chest pain is reproducible. This is not your heart. You're okay to continue to manage at home. This can last for a couple of weeks. And I think some of that, trying to ameliorate some of that anxiety, can go a long way. So I think it's helpful to just remember that most cases are mild, but they're still very uncomfortable. I mean, these people are very sick. If I had $1 for every time a patient told me that they haven't been able to do anything but lay on the couch and watch Netflix, I'd be rich. It's a very uncomfortable disease, but most people will do just fine. Any questions on that case? No. All right. So case number 2, Mr. L. So this is a 35-year-old gentleman. He's actually quite healthy, other than very well-controlled rheumatoid arthritis on rituximab. So on March 15th, he had developed cough, myalgias, fever, and anosmia. So another one of those sort of interesting symptoms that that we're finding sort of unique to COVID-19 as compared to some other common respiratory illnesses, that anosmia. On 3/23, he was directed to our COVID screening tent by his doctor and tested COVID-19 positive by nasopharyngeal swab. So a little over a week later, he presented to the ER because he had persistent fevers, cough, and dyspnea. So here are his vitals from the ER. He was a little hypertensive, but he was satting fine. They documented a normal lung exam, and the chest x-ray was read as nonspecific pneumonia with atypical features. His labs showed a mild transaminitis, hyponatremia, but he overall appeared stable, and so they gave him sort of strict return precautions and had him continue to manage at home. So he called his doctor 5 days later because his shortness of breath was getting worse. And so this was a patient, let's see, when his doctor called me, we always reach out, we try to do as much of the history as we can by phone ahead of time. And he really did not want to come to the emergency department again. He didn't think that he needed to, but he was understandably concerned. So we talked to him. He sounded okay on the phone. He just said he had some lightheadedness, maybe a little bit, and the cough was getting a little worse. So we did elect to bring him into clinic. And so here you can see his vitals. He was tachycardic in clinic. His pulse ox was fine, 95%, but I kept the pulse oximeter on his finger when he walked probably about 10 feet across the hall to get his chest x-ray, and it dropped to 90%. And he was just generally ill appearing. He was laying in bed. By the time he came into clinic, now I had talked to him in the phone shortly before this, and he sounded okay. But by the time we saw him in clinic, he was having 5 to 6 word conversational dyspnea. He couldn't stand for the orthostatic vitals. When I tried to stand him up, he was too lightheaded. He had to sit down. His lungs sounded surprisingly clear, but his chest x-ray showed a worsened bilateral multifocal COVID-19 pneumonia. So really kind of illustrated how quickly patients who seem otherwise stable might decompensate. So he is someone who, here were his labs. So we had him directly admitted to one of our inpatient COVID units. And you can see he has a normal white count. So with many of the patients with severe disease, you're seeing some degree of leukopenia. And then ALT, AST mildly elevated. His inflammatory markers were elevated, including his D-dimer. And then, so they admitted him to the inpatient unit. His pulse ox, the hospitalist who took care of him noted that his pulse ox actually seemed out of proportion to his degree of tachypnea and dyspnea. So he was satting consistently like 93, 94%. but he appeared very short of breath. And so she did a blood clot, ABG shortly after admission, and he had a significant hypoxemia and AA gradient. So he was hospitalized for nearly a week, was treated with O2, the self-proning protocol that we have for hospitalized patients here, albuterol, and he was placed on a remdesivir trial that they are doing in the hospital. And then he was discharged and has been doing fine at home since discharge. And so what are some of our risk factors for hospitalization? And again, this is coming out of that same paper that I showed you earlier out of that Fengkang Hospital in China. So what percentage of those patients who initially sort of have mild disease may progress? So male, gender, older age, I think we all know diabetes, coronary disease, and hypertension. Those are emerging as significant risk factors for severe disease. Low pulse ox, and in this data set, the elevated white count and opacity on chest CTs were also risk factors. We're not doing a lot of chest CTs, so perhaps not quite as helpful. And then also some emerging risk factors include obesity and immune suppression. So in this particular patient, he was on rituximab for his RA, so he had some underlying immunosuppression. Obesity is an interesting one. So obesity has emerged. There's some data coming out of New York that patients who are young, actually, patients less than 60, who have a BMI greater than 30 are twice as likely to develop severe disease as those who have a BMI less than 30. So something to keep in mind, particularly for our young patients, is that obesity is emerging as a significant risk factor. So when you're sort of triaging these patients by phone or managing them by phone, these are the things that kind of give me pause. The other thing is that's being sort of established is that for patients who do end up hospitalized, that dyspnea, the dyspnea and the evolution of severe disease is occurring on average 1 week after the onset of symptoms. So there's that sort of, that window where when patients call you and you know, they're doing okay, but it's 1 week later, 7 to 12 days later, that gets us very nervous. We know that the respiratory decompensation can be quick, and so these are patients who need to be seen, whether it's in the ER or whatever ambulatory setup. These are patients in that window with these risk factors who you would want somebody to have their eyes on. And then any questions on that case, please feel free to unmute and chime in, or any tips, helpful tips that you guys have seen. If not, we can proceed. We have one more case we can share. And I'll let Laurie.
Okay, this was one of the patients that I had seen in some of the earlier days of our clinic. So this is a 62-year-old healthcare worker, near and dear to our heart, right? History of psoriatic arthritis, on Xeljanz and prednisone chronically. So she had onset of symptoms at work on 3/24 with onset of fever, cough, the shortness of breath, and she was dyspneic on exertion right away with some myalgia. She immediately went home as soon as she had any of those symptoms. Notably, this woman had exposure to aerosolizing procedures such as the extubating, so she was very high risk with her immunocompromise and her potential exposures at work. She was started by her PCP on a course of doxycycline, which is something that a lot of docs have been using in this setting. I think sometimes with this viral illness, we're wanting to throw antibiotics at something, and maybe it's us wanting to do something. But as you can see, she was tested COVID positive on 3/27, continued on that course, and really did not help her symptoms really from any substantial gain. So on 4/2, she continued with her symptoms, still fevers, very consistently, despite her Tylenol and whatnot. Was breaking through pretty significantly, cough and shortness of breath. The PCP broadened that was a Sunday, to a Z-Pak and cefpodoxime, and then called us the very next day because her dyspnea on exertion, there was a concern that maybe she was in that window and she was going to be decompensating. And so when I saw her, she looked pretty tired appearing, but not completely toxic. She was still having all of those symptoms, the body aches. She kind of chalked it up to, and honestly, I think that's us healthcare providers kind of minimizing things a little bit, that, oh, I think it's just my psoriatic arthritis flaring up. She did not have any GI symptoms whatsoever. So basically, I did a physical exam on her, and we did a chest X-ray. And you can see from her vitals, she was not febrile when she came in to see us, a little hypertensive. Her saturations were actually really good. She did not have that conversational dyspnea, and I was really surprised. Even with the disposable stethoscopes, which you can't hear very well, she was very junky. She had rhonchi throughout her lungs, inspiratory, expiratory wheezing, really got short of breath when she would ambulate. And I was really shocked that the chest X-ray did not show much at all, really did not match up with the exam. And I would definitely have sworn that this would be for sure a positive COVID. So if you could move to the next slide. Here were her labs. Go back one slide, Em.
Sorry.
That's okay. Here were her labs, and they were substantially normal, thankfully. She had some markers of inflammation, obviously, but very mild sed rate. Maybe some of that is because of her medication that she was on, certainly could be. Platelets were elevated, again, another inflammatory marker, but none of the transaminitis that we were seeing in some of the other patients. And her procalcitonin also was quite low, making a superimposed bacterial infection much less likely, which kind of explains why perhaps the doxycycline was not too terribly helpful. So let's go to that next slide. When we swabbed her for both, although we hadn't been doing that. I know Dr. Achilleos, when he gave his talk last week, was talking about superimposed infections with other viruses, and we have seen those. And so we weren't utilizing those too terribly, but I was very glad that we had done both swabs, which took 2 separate swabs. Her COVID-19 actually came back negative, which I would have lost a paycheck if I had bet on that. But she was positive for human metapneumo. And as a lot of people can be very, very sick with human metapneumo. We see a lot of people hospitalized with metapneumovirus. And I was a bit worried about that. And her PCP did maintain her on those antibiotics for a couple of days. And if you could just go to the next line, but she returned to work on 4/13 and actually did reasonably well. So I think there's a couple of questions there in the chat box.
So I believe Cynthia did address a question regarding people who have chronic illnesses. Cynthia, I don't know if you want to add to that. I always try to follow up on what's in the chat for those who cannot see the chat.
Sure, Jackie. It's Cynthia. There was a really great question about whether or not people who are on chronic immunosuppressing medications should have their regular daily medication adjusted during this period. I've asked that question of a couple of our rheumatology colleagues to ask them, and they are getting tons of phone calls from their patients regarding their immunosuppressants. And so what I've generally heard is, it depends, depending on each individual patient, but they're generally, reassuring their patients that they already have them on the lowest possible doses of immunosuppression to control their disease, and that, you know, they wouldn't want to have any unintended consequence of having flare-ups of their underlying disease if they were to taper down or stop their immunosuppression. So generally, they've been keeping them where they are.
Thank you for following up on that. Is there anything else around that before we move on to two of the other comments and questions?
Yeah, hi, this is Omar. I think I would like to add something on the same lines for our transplant patients, kidney transplant, liver transplant. So that question has been brought up as well. So that if a patient who already has a transplant and they take immunosuppression to prevent any rejection, should they stop it, reduce the doses? So I think the consensus is that the dose reduction should not be done just broadly. I think individual approach is okay if somebody is overly immunosuppressed, so it's okay. But for the most part, I think exactly on the same lines as Cynthia mentioned that we don't need to unnecessarily reduce their dosage and cause them to rejection. Maybe Dr. Kroc, do you want to share your experience for liver transplant patients?
Yeah, actually, unfortunately, there have been 2 liver transplant patients that have ended up with COVID-19 in our ICU. And we are very fortunate that they both have done very well and they both have been discharged from the ICU. And so I think it just really is important that as physicians, we make sure that our patients are always on the lowest dose of medications that they need to be on. But I think it also brings up that very important point that these patients might have a more prolonged course than other people, and we need to be following these patients more closely than we would if they were not on immunosuppression. But so far, the 2 that have been in the ICU have both recovered and are at home.
Thank you both for providing that input. Bill has, I think the first one is more of a question or a comment, but I'll pose it as a question first. He indicated that many patients who died in 1919 pandemic, 1918 pandemic had secondary bacterial pneumonia, but that was pre-antibiotic era. So I don't know if there are any comments or questions around that before we move to his other question.
So I think we're all thinking in this clinic that we were going to see an awful lot of superimposed bacterial infections, and certainly the chest x-rays and the physical exams that we have been doing here are not really bearing that out. Whether that's a surprise or not, I'm not really sure, but I still think there is an awful lot of antibiotic use, certainly. And whether that's warranted or not, I think that's certainly a discussion point, and hopefully down the road we'll have more guidance on that. But we haven't really been seeing that, Emily. Like even the folks that we see and we reevaluate after several weeks, when you think, yeah, it's been long enough, we think that their course is probably with a superimposed. At least our N is very small here, but we haven't been seeing that.
Thank you. And Bill then also asks a second question, as pulmonary hypertension is seen in patients, any use of Viagra for dyspnea?
So I'm not familiar with any, I'd have to look into that. I'm not familiar with any studies supporting that. I certainly use a lot of Viagra in my pre-pandemic practice, but not for this.
So are there other questions or comments either on the lecture or the cases or any other scenarios that you're seeing?
Emily and Laurie, could I ask, when you set up this clinic, how was it decided who would be in the clinic? And how many people do you feel you need to have in the clinic? Obviously, I believe some continuity is probably needed. Perhaps you already mentioned that, I'm sorry, but how did you guys decide who would be?
So we made this clinic absolutely positively voluntary. The medical group staff was everyone that had volunteered to come over. So the LPNs, the RN, everybody was volunteer from a staff standpoint. The x-ray techs were sort of volunteered, I guess. But definitely all the doctors, and the response was pretty amazing. Like when we put it out there that this was, yes, we'll be on the front line and that this will be completely a voluntary effort. It was pretty amazing how many people were basically chomping at the bit to, be out there and to really do something, and I think at the end of the day, it's a very tight group, by the way. I think because of that, from the nurses to the x-ray techs, all of us, we're not afraid to tell each other, you're not being safe. And so that's basically how it was mostly decided. And we ended up having to recruit again by volunteer, some of nurses from family community medicine so that we would be prepared to see children here. We have family community medicine doctors here, all volunteers, so that they can see some of the younger patients as well. Although that hasn't been borne out. We saw the one 14-year-old, and I think that was as young as we have gotten in the clinic. But it really has been a group effort with people who are highly motivated to take care of these patients. So that's how it was set up and came about.
Yeah, and I would say we didn't, thank you, Karen, we didn't, Laurie and I didn't set this clinic up. The medical group was actually really proactive, and they set it up, and then Laurie and I kind of like moseyed in and put some scrubs on. But in terms of how many people, that is, I feel like the $1 million question. So looking at the early modeling, we thought we were going to be terribly busy this week, and fortunately, we're not. And so I think it remains to be seen as we move forward, and in some of our social restrictions and the shelter-in-place order goes away. I think most of us are anticipating maybe not a spike, but somewhat of an increase in patient volume. But that is, gosh, that is anybody's guess. And I don't know if anybody who's on right now has any insight into that, because we just don't know.
So before we jump into a different topic, Janet asked how many patients are seen in a day typically? And if you could tell us again the location and hours.
Yeah, so the hours are 8 to 4, and right now we're seeing about 6 patients a day. So again, we anticipated that demand would go up. And so, I mean, if we go back to my last slide, it has our Tiger text on it. So anybody you want to refer, please feel free. We have plenty of space for your patients. But the hours are 8 to 4, and we're certainly not overburdened at this point. And there's a question too about adding peds. So we did specifically make sure that there's always either a family and community medicine doctor or Dr. Buckberger, who I see is on the chat too. He's a pediatrician as well. So someone is always here who can see that age group. Certainly, if there's a need, if a pediatrician wants to come over, if there's a peds need, we'd be happy to bring them into the fold. But we don't have a pediatrician here all the time. Next week, Glenn's here. Send all your children.
And there's another more logistical question. How many phone calls to COVID positive patients currently at home?
Oh, lots of phone calls. So Dr. Andreas Achilles gave a great echo talk last Friday, and he'd probably be the better position to answer this, but there are a lot of phone calls to patients currently at home. And I can tell you, even, the patients who we get referred here in clinic, you look in the chart and there's usually a daily phone call from either their family doctor, their internist, leading up to the point that they get to us. So these patients really need to be closely followed.
And I would have to say kudos to the monitoring, at least here at Hershey Medical Center, both through the family community medicine and the general internal medicine folks that have, they're the PCP for folks. And even those that they're following folks that have run through our tent that we are not their PCPs, but we're still following those on a very frequent basis. And I think that's made a monstrous difference. We mentioned about the anxiety that all of these folks are having, and understandably so, but it is really people's reserve at this time are very, very thin. And the anxiety is playing a huge component, and we have people that want to come in to be seen, but maybe they're best served at home, and with a daily phone call, maybe that anxiety can be addressed, and they feel better, quite frankly. And so there's a lot of care, true care, that has to go out to all these patients. And the monitoring that the folks are doing here is really going a long way to assuage a lot of fears.
Yeah, because again, going back to, most of these patients will have mild disease, and most of these patients do not need to, whether it's the emergency department or the COVID clinic, they don't need to come in here. And I would say every single consult that we've had so far for bringing a patient in is very appropriate. And there's usually been multiple, not just one, but multiple interventions that family physicians, internists have tried before they get to the point of sending them in here. So that's another point. Like, we're here if you need us, but certainly most of these patients can be sort of managed at home just fine, and should be managed at home.
So Laurie, someone had provided an update on patient 3. Did you want to go through that and follow up on that for us?
Yeah, Steve Henderson, identified as the PCP with my patient. She was held on the Xeljanz. I think that you put her back on, or she was put back on the Xeljanz right about the time right after she saw us, I think, Steve. And then, but she really did well. She sounded awfully junky to me on exam, to be quite honest. And the X-ray really did not equate to that. So I would have been pretty conservative with her, as well. So, and you did get her back to work, I saw, on the 13th, which is great.
Thank you. Are there other questions or comments?
I thought that was a great question that someone asked about how many phone calls and how people are being followed up. Unfortunately, I was not able to attend Dr. Achilleos's talk, so I'm not sure how much he went into the algorithm that was developed. It is by no means an algorithm that is, it is the algorithm that's been developed at Penn State Health for our patients. And so if people were interested in that, we can share that with the Echo platform people, and that could be emailed out potentially, or if you have questions, or you could go back and look at Dr. Achilleos's talk. But patients are divided into high risk, medium risk, and low risk, and that determines how frequently they're called.
Melissa was the one who earlier brought up about peds in the clinic, and I just wanted to make sure that she had no other questions around that. It sounds like she was looking for maybe some input. I know we haven't had that yet, but does anyone have any other information for her? Or Melissa, did you have other questions?
Hi, this is Melissa.
Hi, Melissa.
So my question, so I'm in Lancaster with the community medical group. I'm one of the pediatricians. And with the consolidation, we have moved out of our normal multi-specialty location, and we have taken over one of the poor family practices, got booted from their site. So we have their building just for peds, and we're mostly seeing well babies with well parents. But we are starting to see more COVID positive moms in the hospital delivering. And we're trying to figure out the safest way to see those newborns then. Our plan is to have a healthy caretaker bring the baby in, but sort of by definition, those caretakers are going to be PUIs. And we do not have the ability to do negative pressure. We own one N95, and that's mine. So I'm just not really sure how to best, I should say we own one fit tested N95. Nobody else passed with the only N95 that was available to us at the time. So I don't even have a nurse that really could see a PUI. I don't have a negative pressure room. We do have a back door when we bring sick kids in. They come through a back door directly into an exam room that's in a separate area. And we're separating our staff and our providers. So I'm one of what we call the dirty docs, because I'll see sick patients. And our clean docs are seeing well babies. But this doesn't feel like a situation where one of our clean docs would safely see the baby because the parent is a PUI. So I'm just wondering if you have any guidance without the great setup that you guys have up there that we could do locally to safely see these babies as they start increasing.
Gosh, yeah, that's tough.
That's a tough one.
Yeah.
I would say falling back on some of the guidance when we set up this clinic, you know, probably the number one thing that protects us from the COVID positive patients is putting a mask on that care provider, even the PUI. Well parent should definitely have a mask on, surgical mask if you have one to give them prior to them even entering anywhere, and have them touch as little as they possibly can wherever you are. And that's one of the guiding principles that we do here, trying to keep us safe, is and in cleaning the surfaces afterward. But I think your providers and your nurses should certainly be suited up in protective gear to see these folks, most certainly. And the washing of the hands is huge in between every step of putting the PPE on and off, particularly off. If you have N95s, N95s are probably the way to go, but certainly your infectious disease control folks. But those are some of the tips that we got from our infectious disease control folks to keep us safe here. And so that's tough.
Glenn might have something
Yeah.
to add too.
Yeah. So Glenn the pediatrician here. If all else fails, certainly having the baby brought in with a healthy caretaker, with the protocol that Laurie just mentioned, is effective. There's good data out of China showing that bringing people straight back to the exam room, having no contact with front desk staff, carefully masking all persons under investigation. That can be very challenging with the newborn baby, who we do technically also think of as a person under investigation.
Right.
But with good wiping down of the exam room afterwards, and at the very least surgical masks and face shields for providers, the infection rates in China were actually pretty low after the initial blip. Now, ideally, you'd be able to do some of these assessments via telehealth, and we have had some ability to secure, I can't remember who the vendor is right now, it's blank, I'm blanking on it, to get some base model infant scales to actually go home with persons under investigation, to be able to at least do weight checks from home. And if a baby appears to be jaundiced, having them come in for a lab-only visit. There are some ways to do the newborn visit, the weight check from home. It's certainly far from ideal, but
Right.
I think, Melissa, probably the main data point that we're after is the weight. So if you have a way to get a scale home, you might be able to get by for those first couple of weeks and get yourself past the PUI period.
Okay. I know we're in a unique situation because we're sort of straddling two health systems. So we are obviously Penn State Health, but the hospital here in Lancaster is a Penn Medicine hospital, where all of our newborns deliver, and we're actually on staff at that hospital and around there. And I know they are trying to set up the ability to do home scales, but they have not been able to accomplish that yet. So we're sort of stuck because Penn State Health is willing to be very helpful with that situation, but until the baby actually goes home, they're not considered a Penn State baby. Like, it's all very confusing with two hospital systems involved. We're sort of straddling the two systems right now. So, but I appreciate the input. I think it sounds like we could, at least with me in full gear, because I do have a fit tested N95, but I could probably safely see these families through the back door in our what we consider our sick room, if we have to. Thanks.
And I think that if sort of modifying the COVID clinic procedure such that if possible, you could do these newborn PUI visits first in the morning. Because with rare but important exceptions, we usually know when a newborn baby is coming, and you might be able to schedule these things first in the morning.
Right. Thanks.
So thank you all for that input. And Umar, thank you for the suggestion of inviting our OB folks to discuss this issue. What I can do is ask that our ECHO team follow up with them again and see if they have any additional information that we can share in a follow-up